So I would like to talk about several things that affect the diabetic person. Urinary incontinence, although it's not naturally caused by diabetes, it is a curse in diabetes. And in my previous times I used to visit Darwin, and diabetes and incontinence and in the tropics is just true misery. So we'll go through some of the causes of incontinence, talk about the male sling and artificial urinary sphincter, which works for both men and women. Then we'll talk about erectile dysfunction, which is quite prevalent in the diabetic population, and the causes and treatment options. And I'll talk a little while on Peyronies disease, which is something you may not have ever heard of, but is certainly much more common in the diabetic population. And then we'll talk about the atonic bladder. When I dictate letters about the atonic bladder, the secretary invariably types atomic bladder. So incontinence is basically the involuntary loss of urine because of bladder dysfunction or sphincter dysfunction. There are various types. The commonest probably is the stress incontinence, which invariably follows multiple childbirth. It's leaking during physical activity that increases the abdominal pressure, and then the sphincter is not strong enough to contain the urine, and then leakage occurs. The other group that commonly occurs in is after men have prostate cancer surgery. Urgent incontinence is where the bladder is sending signals that it's going to contract, and the person just can't stop the loss of urine. Now, that's where you have mixed incontinence, that is, people who have weakened sphincters and they have even a mild overactive bladder are incontinent. That is, they just can't hold the urine back. So people who have an overactive bladder where they have normal sphincter function, but they have very high pressure contractions and they lose urine. Or much more common is the mixed, where you have an overactive bladder and the sphincter mechanisms are weakened by childbirth or prostate cancer surgery. So pretty much the issue is the sphincter mechanism around the pelvic floor area. That the bladder is effectively just a simple reservoir that works as a pump. That as it fills up, it empties. It fills up, it empties. And it's the only basic function of life that you have voluntary control over. All other functions, breathing, heart rate, intestinal function happen automatically. The bladder is the only one that you have any sort of control over. And obviously a healthy sphincter stays closed until it is relaxed to enable urination in a decent manner. So the incontinence is usually to do with childbirth. Prostate surgery is the big one in my practice, and pelvic surgery or trauma, pelvic fractures, and spinal disease and neurological disease such as Parkinson's or multiple sclerosis are all causes of incontinence. So if you're wet, I can pretty much guarantee you can be made dry. How do we do that? Well, why treat incontinence? It's many times I've heard men and women say that they just don't want to leave the house because of the issues of incontinence and in particular smell. They have a perception that everybody can smell them, and it leads to a poor quality of life. And now I will mention the Continence Foundation of Australia on their website has a map of every public toilet in Australia. And you might think that's trivial. It's not. Some people live by that. So if you look at the issues of incontinence, particularly male incontinence, it's the extra laundry. That one wet bed is a major problem. There's expense with the pads, and there's, again, skin irritation and issues with the effectively nappy rash. So in talking about incontinence, case in point is a few years ago in 2015, I was seeing a man who was 79 years of age and he'd come back to see me to arrange a medical alert bracelet. In 1997, he'd had prostate surgery to treat his prostate cancer. Effectively, he was cured of cancer, but he was incontinent of urine from day one. And then 8 weeks prior, we just put an artificial urinary sphincter in, and he was completely dry. And as he was leaving, he said he was now dry after 17 years. He was very happy, but he left with the comment, "If only I had known about the procedure." So that's one of the reasons for talking about this. So management options, you can have pads and pull-ups. You might think there's pads, but there's pads and there's pads and there's pads. And we have continence nurses, particularly at REPAT, that have been very helpful for many men and women with choosing the right options for their continence. There's medications that particularly are useful in the overactive bladder, and there are devices which I'll go through. Some of those pads can hold up to 5 litres. It's amazing. And there's obviously the lighter pads, but there are the maxi pads, and they come in various different from various different manufacturers. So in the past, I've been very dismissive of the penile clamp. Its advantages are it's non-medical, there's no operation, it's easy to use, and it works well. Previously, the big disadvantage was the fact that it could cause gangrene of the penis. That is, too much compression and you lose blood supply, and then you have necrosis. That's all changed. There's a new device called a dribble stop that has these foam cushions that make it a very safe device. And I've prescribed this for a number of men, and that as a temporary solution, it's brilliant. The most recent was a farmer that wanted to get his harvest done before he had anything more done, and he made use of the dribble stop and was completely dry while he was doing harvest, and then we talked to him about other things later on. A catheter is pretty much the urologist say, "I've given up, it's too hard." Catheters have their own problems with infection, they need to be changed regularly, so they are an option, but they're not a brilliant long-term option. The big issue is infection. So one of the things with the overactive bladder is that we just ask people to void frequently and decrease fluid intake. Common sense, you would think, but many times I've had the man or woman having 10 cups of coffee and they wonder why they've got a bladder problem. It's usually the young Italian man, and before he sits down in the office, I say, "How many cups of coffee?" And he says, 8 to 10. I said, Pelvic floor exercises, particularly in the women who've had multiple births, are great. They cost nothing, they can't hurt, and they can help to varying degrees. So we always say, if you've got stress incontinence after childbirth, then let's just get on the pelvic floor exercises for 6 months and see what happens. And I can't emphasise that enough, actually, because many times we've solved the problem with the pelvic floor exercises, and it's just unfortunate that the person didn't know about it. We can inject bulking agents inside the sphincter mechanism to increase the power of the sphincter. Not very successful, and used to be much popular before we had the various slings, but it exists as an option, and it's like a day case procedure. We used to use collagen, but more recently we've used silicone paste or beads. Now I'll talk about the solutions that are much more effective, both the male sling and the artificial urinary sphincter. So the male sling, it supports the sphincter mechanism and is only useful in light incontinence. That is, if you've got lots of pads and moderate to severe incontinence, then a sling is not appropriate and won't work. It's a very simple procedure. nothing to operate, so it's a passive device as opposed to the artificial urinary sphincter where you have to activate it, and it's completely inside the body, and it's just there and it just works. So that's the actual sling itself. It's a polypropylene knitted mesh. As one of my patients calls it, fancy shade cloth. Effectively that's what it is though. It's a knitted, it works as a hammock to support the sphincter when there's physical activity. And it just sits external to the pelvis, but its arms go inside the pelvis, and that's how it's anchored. But as with all things, there can be a downside. So this is a urethral sling that has eroded through the back of the urethra and caused problems, and then subsequently had to be removed. Artificial urinary sphincters, if you like, the gold standard. It's a procedure where patient comes into hospital and we do probably about a 90-minute operation, and it's very effective. If a man or woman, but mostly men, have an artificial urinary sphincter and it stops working, they are in the office the next day because it's given them such good control. That's the actual device. So you have a pressure regulating balloon, you have a pump in the scrotum, and this little cuff goes around the urethra, which is the pipe that you urinate through. And amazingly, 1 ml of fluid in that cuff gives you complete control. So it's for both men and women. I must admit we very rarely put them in women, but the men, it goes around the cuff. The cuff goes around the urethra in the base of the penis. In women, it goes around the bladder neck. So to insert in a male, it's a cut through the skin of the perineum. In a woman, it's a big pelvic procedure. So quite a different access. Artificial urinary sphincter is not for everybody. If you've got terrible rheumatoid arthritis, for instance, and you can't use the pump, then it's not appropriate. And we used to say if you have an overactive bladder, it's not appropriate. Well, that's no longer the case. And if you have allergies to the tetracyclines, we can arrange for a device to be made that doesn't have the antibiotic coating. So incontinence is a fairly common problem, and there are multiple treatments depending on the severity and the cause of the incontinence, and you can be dry most times. Does everybody have any burning questions? Yes, I do prostate surgery as well for blockage. Okay. Erectile dysfunction. Sorry, you had a question? I have a question at the end. Okay. Erectile dysfunction, that's just the persistent inability to maintain an erection firm enough to have sexual intercourse. Quite common, particularly in diabetic men, and most men are reluctant to talk about it. Causes, top of the list, diabetes, and then heart disease, and then another common group is the men having treatment for prostate cancer, both with surgery and radiotherapy. Can be related to medications, particularly blood pressure medications, and things like testosterone deficiency. And as I was talking to my daughter studying vet science last night, he said, "Why are you talking to Diabetes Australia?" And I said, "Well, diabetes affects everything. It makes everything worse." And he said, "Oh, like smoking." So, diabetes and smoking. If you're a smoker and you're a diabetic, you're going to end up with erection problems. Stop it now. So I can talk to a man about his erectile dysfunction, and I can look him in the eye and I can say, I can give you a rock hard erection. So I can show you a rock hard erection that lasts for ages. So this is a waterhole marker, probably erected by Indigenous Australians. It's just west of Lake Torrens, a place called the Chimney Hole, and that erection could even predate the pyramids. It could be 40,000 years old when you think about it, because they've been around for a while and the waterhole was always important. Anyway, back to diabetes. Treatment options. Before Viagra, we have very few options other than the injections, the vacuum devices and the surgery. The Viagra, when it became available, and then the medications that followed, the Levitra and Cialis, particularly the Cialis in diabetics, made a huge difference. So we'll talk about the vacuum erection devices and the injections and the penile implants, but pretty much most men with erectile dysfunction will start off with the Viagra or the Cialis. That's the various tablets. The blue one's the Viagra, that's the Cialis, and that's the Levitra. All of which can cause facial flushing and headache because they both dilate the blood vessels, and that's how they achieve the erection. It's a curious thing. I've got a headache tonight, dear. So with the diabetic man, the erections start to fail and they will start on the medications. Most times, eventually, the medication will stop working and they'll end up with one of the other options. Many times I've had men, when we've put a penile prosthesis in place, they say, oh, I probably should have had this done 5 years ago because that would have saved me a heap of money. The issue now, though, is Viagra is now $2 a tablet as opposed to $20 a tablet. So if you're needing Viagra, shop around, and if you go to online pharmacies in Australia, you can get it down to $1 a tablet. So that's been a huge change. Vacuum device, that works by putting a cylinder around the penis and then creating a vacuum in that cylinder, and that draws the venous blood into the penis so that you can have an erection. Now that picture is false because it's not an erection that stands up. From that point below, it's soft. So it's not an erection that stands, it's an erection and it's usable, but it does mean you have to have equipment to clean and carry. It's not a popular choice. Injections, where you put a prostaglandin directly into the penis, that causes fixed increase in blood flow, and when it works, it's an erection for 30 minutes. It's a good option for the man who's got significant ischemic heart disease, because the Viagra and the Viagra-like tablets can cause issues with nitrates, but it is the use of a needle. So now we'll talk about penile prosthesis. So a penile prosthesis is plastic hydraulics that go within the penis. There's a reservoir that's put in front of the bladder behind the pubis where you can't see or feel it, and in the scrotum is a pump that is used to inflate the hydraulics and cause the erection. Most men who have them are very happy, sort of well above 90% happy, and compared with the tablets and the injection, it's a much better option because it's a very reliable injection. And as a result, I often talk to diabetic men about placing one of these early rather than waiting until all other options are exhausted, because it's such a reliable option. It's been around for over 30 years and very high patient partner satisfaction. There are different types. There's the one-piece non-inflatable, which is very cheap, very easy to use, but I've never put one in place because it's an erection that's always erect. The only real reason to have one of those is if you have poor manual dexterity and you can't use a pump. There's the two-piece, which is easy for the surgeon to insert, but is much more bulky because the reservoir is in the penis. And then there's the three-piece, where you have the reservoir tucked in front of the bladder, and you have the hydraulics and you have the pump. And that's a much more natural erection and a much more natural non-erection. So just, again, the one piece is Simplest surgical procedure, least expensive, but it stays firm and erect and may show through clothing, and not a popular choice. Two-piece is a step forward, but really that is the two-piece. The fluid that causes erections is contained within the cylinders, which are contained within the penis. The three-piece is my definite preferred option. It acts and feels more like a natural erection, expands the girth and length of the penis, and much more firm and full than other implants. It does require some dexterity for the user or users, and there's always a risk of mechanical malfunction or leakage. They say 98% are still working at 5 years, so it's still a pretty reliable procedure. And pretty much the only problems are those related to infection and related to mechanical failure with time, which can be an issue for a 40-year-old man who's got many or decades of use ahead of him. The prostheses are now coated with an antibiotic, and since that coating of antibiotic has occurred, I've not had one infection with the primary insertion of the prosthesis. And the results are pretty much a natural stand erect erection. And most people would recommend it. So the penile prosthesis achieves a natural erection easily, and it is maintained as long as the man wants, and works every time. Downside, it does require surgery. There are always the risk of surgical complications, either with the anaesthetic or with the operation. And if there's private health insurance, that's covered by the private health insurance because it's on the prosthesis list for Australia. If the man doesn't have private health insurance, looking at sort of $15,000 for insertion. If the man hasn't had an erection for a long time, you can get pain with the initial erections, and once we do the penile prosthesis, there's no going back. In summary, erections are a common problem, and nearly every man can be treated for erectile dysfunction, and penile implants are a dependable long-term solution. Any burning questions? Yeah, that little boy's quite a bit bigger now. So I'll just talk about Peyronies disease because it is much more common in the diabetic man. And in the diabetic man, if he has Peyronies, then erectile dysfunction is much more common too. It's abnormal scarring of the penile hydraulics, and it's where the scarring occurs on the surface of the hydraulics that causes that part of the penis to be inflexible. So when he has an erection, he can get 90-degree deformity. It really can be quite staggering how bad it can be. The degree of deformity can vary, and obviously the more severe the deformity, the more difficult the treatment. So the impact of penile deformity is, if it's trivial, then we say don't treat, but if it interferes with the sexual penetration or causing pain for either partner, we say we should treat. So the issue is that the scar tissue causes a shortening of the hydraulics, and if we correct the deformity by creating a pleat on the opposite side, we get shortening of the overall erection to the length of the shorter side. It can cause pain, and we invariably say don't treat whilst there's pain. You can have a congenital curvature, which is not Peyronies, and it usually will follow a penile fracture. And our penile fracture is where you have the erect penis bent with great force, and it is usually a drunk woman on top. And it snaps like a carrot. there's bruising and immediate loss of erection. And things we need to rule out, things like sarcomas and penile cancer. Who gets Peyronies? Guess what? It's the diabetes guys. Can be anybody, and usually there's a family history of Dupuytren's contracture, which is scarring of the tendon sheaths in the hand. And you can get a similar thing in the feet. Yeah. And it commonly affects men in their middle age. It's not an old man's disease. We think that it's probably the usual cause of Peyronies is the congenital or the underlying abnormal scarring from minimal trauma. So we know that men who have Dupuytren's contracture of the hand, if they're office workers, they won't form it. So same thing, if you had the predisposition to Peyronies and you didn't make use of your erections, you probably wouldn't get it. But of course, men rarely do that. The scar tissue forms in the wall of the hydraulics. So it's nothing to do with the skin, and it's nothing to do with the urethra. It's to do with the wall of the penile hydraulics called the corpora cavernosa. So there are a lot of treatments for Peyronies, and you might think, well, that's good. No, it means none of them work. Over the years, we've prescribed things like colchicine, vitamin E, injections into the scar tissue with steroids, but I can tell you that I stopped recommending those treatments about a decade ago because it was just wasting the man's time and money, and sometimes cause some pain if using the injection therapy. There was even use of the interferon, and as well as things like iontophoresis, where electrical current was passed through the penis. All these things are not effective. Things like extracorporeal shockwave therapy to break up the scar tissue, penile traction and vacuum devices have been shown to help, but certainly not dramatically. So the things that do work are something to dissolve the plaque called Xiaflex, where we inject this enzyme into the scar tissue. Things where we actually excise the plaque and put a graft in, that's not very common, but much more common is the plication or causing a pleat on the opposite side. And for the man that's having erection problems already, well, then we don't think too hard. We start talking about a penile prosthesis from the start. And that while the man's anaesthetised, we can literally break the plaque by flexing the penis with the penis erect. So Peyronies is a surprisingly common disorder, 1 in 200 men. So there'll be some men here today that will have Peyronies disease. It's abnormal scarring, and it affects 2 people. Non-surgical treatment is the Xiaflex, and there's surgical treatments are invariably the what's called the Nesbitt procedure, which is the pleats on the opposite side, or the penile prosthesis. Just a quick chat about the autonomic nervous system and bladder function. As diabetes progresses, it's not uncommon to have an autonomic neuropathy, and that directly affects the nerves to the pump, and the pump ceases to work normally, and the man or woman is left with something called chronic retention. And that means the bladder's not emptying out, and the man or woman is carrying 500 mils to a litre in the bladder, which is a stagnant pond, which is a setup for infection. And infection, if you've got 500 mils of urine in the bladder, is much more significant than if you've got 50 mils in the bladder, because you have 500 mils of bacteria-laden urine, and that makes you very unwell very quickly. The autonomic nervous system problems in males and the atonic bladder in males is much more of a problem because they most times have an intact prostate, and that causes bladder outlet resistance. And that is a setup for men to have a lot more trouble with their bladder than the women with the autonomic nervous system problems. But there are some treatments where we can give a stimulant to the bladder that causes the bladder to contract more effectively, and sometimes we teach men and women to intermittent self-catheterise, that is, to pass a catheter themselves to empty out the bladder so they're not carrying that litre or that 500 mils of urine. Sometimes, particularly in women, we'll talk about a suprapubic catheter, or in men, the urethral catheter. And if you are having to wear a catheter and it's because of an atonic bladder, we almost always would suggest a tap rather than a bag. That is, you let the bladder fill up and then you empty it out. So you don't wear a bag on the leg, you use your bladder as a reservoir. That's it. Any questions now? Yes?
My husband's got prostate cancer, but he had hormone injections, but they said it'd only be a little while, but he's put on a lot of weight. Is this right that it'll go up if he has more injections, and will it stop after the injections?
Yep. So standard treatment for prostate cancer, if it's in an older man or it's not easy to cure, is injections that stop the body from producing testosterone. So effectively it's medical castration, and that means that he doesn't have the same level of endurance, so he can't exercise as much as he could. Other things like depression and loss of muscle mass and incoordination, so much that I always recommend that the men that start the hormone treatment don't do any ladder work or roof work. But the putting on of weight is because he's eating the same as he has been for previous years, but he's not exercising and he's not burning those calories. So he just pretty much has to look at you, and he need to look at his diet and make the appropriate reduction in calories. But it's just simply that he's not exercising as much as he used to. And yes.
What age would you do, guys or men, with the implant? What age would you go up to?
Oh, what's the oldest one? Oldest one's 80. Yeah, and you might think, but you know, it's the young partner. Yeah, and you know, he was amazingly fit, and he wanted to have erections. So fair enough, we'll help you out. But yes, people constantly surprise me. And if you don't ask the questions about their sexual health, you often will miss a big part of their story. Yeah, otherwise known as Eurocarb, but bethanocole's its proper name.
What is it? Is it a tablet or?
It's a tablet.
Right, so taken all the time?
Yeah, it's you have to take it 4 times a day because it's got quite a short duration. But about 5 years ago, the company stopped importing it, or stopped. We ran out of bethanocol, and suddenly there were hundreds of men and women that couldn't pee. It was like the ad. It's like the company had created an ad for itself. It just showed that it was very effective, and there were all these people that were taking it that had a real benefit. And when they couldn't get it, they were in real trouble.
Sorry, what was the other name for it?
Eurocarb.
Eurocarb, thank you.
Sometimes I get questions that are far too revealing. So if you have erectile dysfunction, just talk to your GP about it initially. Okay.